Hi, everyone. I'm Dr. DeVito from Duke University, and I'm going to talk about the management of microsatellite unstable colorectal cancer today with a focus on the ATOMIC trial and recent data from ESMO 2025. So we know that MSI status is mandatory and should be considered part of the diagnosis of colorectal cancer. This should be something that's reflexively done by pathology. And patients that are going to be treated with systemic therapy should be treated with immunotherapy, not chemotherapy, in the frontline setting, which further emphasizes the importance of having MSI status at diagnosis. There is one exclusion to this is that patients who you have significant concerns about toxicity, you should consider excluding ipilimumab, but we'll talk about why we should not be afraid to add ipilimumab in these patients and manage the toxicity. Chemotherapy is therefore a second-line therapy or later when trials are not available for microsatellite unstable colorectal cancer. We know this, and what has informed our practice and confirmed it is the CheckMate 8HW. And this is in stage 4 microsatellite unstable colorectal cancer, where they randomize patients to receiving either nivolumab, or ipilimumab, so anti-PD-1 and anti-CTLA-4 therapy, or investigator's choice chemotherapy of a FOLFOX FOLFIRI backbone with bevacizumab or cetuximab. And what they saw was a result that you could drive a truck through, even one that says MSI on the side, is that it's very obvious that if you give patients immunotherapy first with microsatellite unstable colorectal cancer, they do significantly better than if you expose them to chemotherapy. And they also don't acquire the side effects that go along with chemotherapy, some of which can be permanent. So this clearly establishes Ipi/Nivo as the first line standard of care for stage 4 MSI-H colorectal cancer. And again, the side effects are very manageable. If you look at the grade 3-4 rate of Ipi/Nivo versus Nivo, it's 22% versus 14%. So you're not really getting a lot more toxicity with the addition of ipilimumab, but you are getting a significant overall survival benefit. And so I think it's absolutely worth adding the ipilimumab, even if you get a patient through only one dose of it. We know that CTLA-4 therapy leads to TCR epitope spreading and leads to more recognition of more neoantigens and thus longer-term disease control in these patients that's borne out in overall survival. So again, I think this side effect profile and the profound overall survival that's seen in CheckMate 8HW with Ipi/Nivo versus Nivo alone, or certainly versus chemotherapy, justify this as the first-line standard of care treatment. So prior data to data in the metastatic setting, it was really hard to know what to do for these patients that had locally advanced MSI-H colorectal cancer. We really had a lot of equipoise there and didn't know how to manage them. So FOLFOX was often given in the adjuvant setting in your stage 3 MSI patients, even if that would not necessarily be appropriate or what we would intuit scientifically based on our knowledge to date. What we know now is that upfront surgery has to be done many times in colorectal cancer due to obstruction and other considerations. Then we could look at adjuvant immunotherapy, and we'll talk about that a little bit. But the best option includes neoadjuvant immunotherapy. In melanoma, where it's well established that giving immunotherapy before a tumor and the lymph nodes that are associated with that tumor are taken out, we should give the immunotherapy, expand that TCR repertoire, and make sure that we get long-term immune memory. So with the tumor in place, the lymph nodes in place, this acts almost like having an in situ vaccine as opposed to just blocking checkpoints when there's no tumor around. So the best case scenario with microsatellite unstable colorectal cancer is that you're giving upfront immunotherapy with the tumor in place. So now we're going to talk about ATOMIC. Is it the bomb or is it a bomb? So, ATOMIC, MSI-H colorectal cancer randomized to either FOLFOX or FOLFOX-Atezo and then more Atezo. So again, this trial was designed before we really had a good idea of what the first-line treatment of microsatellite unstable colorectal cancer in the metastatic setting should be. So there was some equipoise of understanding how we should treat these patients. And the standard of care at the time was giving them chemotherapy. However, you would not give chemotherapy in the metastatic setting now in 2025. So why would you give it in the adjuvant setting to a patient who has no tumor in place, potentially exposing them to toxicity with absolutely no benefit? So even though the disease-free survival curves look better with atezo and FOLFOX, there's no atezo-only arm. And I can almost guarantee that it would look similar to that in FOLFOX and atezo arm, and not the FOLFOX alone arm. So this was not a practice-changing study other than the fact that it gives us access to atezo in the adjuvant setting for patients that have had to have a surgery. There was no real difference in any of the subgroups. All of the patients benefited from the addition of atezo, which really tells us that the atezo is what's doing the work and potentially, if not all of the work. So the overall survival data here are not mature. I don't really intend to follow up on this again because it's not really a practice-changing study for me, but it will be interesting to see how it affects, other people's perception of the study once they get overall survival data. I predict it will be much worse in the chemotherapy arm, which would confirm what we're thinking here. The overall survival comparison also may be confounded by the fact that many of these patients, especially those who got chemo only, they relapse. And what do you give them when they relapse? You give them immunotherapy, hopefully ipi-nivo. So what this should do to our practice is confirm to us that we do not need to be giving chemotherapy to patients with MSI-H colorectal cancer, not in the metastatic setting, not in the adjuvant setting, and certainly not in the neoadjuvant setting. Atomic does, however, offer an approval avenue for adjuvant atezo, and I think that this is a great way to get your patient adjuvant atezo after they've had a stage 3 colon cancer that was obstructive removed, and that way you're giving them some adjuvant therapy as we accumulate more data here. What really started to put an end to any discussions of whether Atomic was a standard of care and whether I think neoadjuvant therapy is better than adjuvant therapy, these kind of tenets that we're seeing in melanoma and now in MSI-H colorectal cancer, were the Foxtrot and Niche2 studies that were presented in ESMO 2025. So I would call this the quick rise and fall of Atomic after ASCO earlier this year, because what we can clearly see here is a disease-free survival of 100% in patients that are treated with neoadjuvant Nivo IPI. It is very, very, very obvious based on this data that this should be the standard of care whenever we can get patients to neoadjuvant immunotherapy with MSI-H cancers, and not we should be considering adjuvant anti-PD-1 and as we accumulate that data. So I thought this was really striking. Here's the data broken up a little bit more, and I think that it was pretty profound that even in the T4 patients, these patients did extremely well. So ipi-nivo is really the standard of care once again for locally advanced microsatellite unstable colorectal cancer, which is why that biomarker is part of the diagnosis and why we should be trying to give these patients treatment before they go to surgery. Rather than giving them adjuvant therapy, this could potentially give them a less morbid surgery and significantly better outcomes. So what are our conclusions here? On stage 4, again, MSI-H colorectal cancer, we know that ipi-nivo improves overall survival and should be the first-line treatment. There's no role for chemotherapy in first-line, stage 4, or locally advanced MSI-H colorectal cancer. And ideally, locally advanced MSI-H colorectal cancer is treated with neoadjuvant immunotherapy prior to resection, or in many cases, avoiding surgery altogether. You can consider adjuvant anti-PD-1. I don't think there's quite enough data to give adjuvant anti-CTLA-4 here. Hopefully, we're going to learn more about this with ctDNA and further trials in the future. So once again, thank you for attending my Atomic Disc Track. I really appreciate it, and I hope that this informs your practice.